Yeah, good evening, everyone. This is our meeting. Every Tuesday, we have a meeting at 7 p.m. So it's a critical care and emergency medicine meeting. So we have today an interesting topic, actually the decoding of the resistant bugs. So different types of resistant bugs we see day to day in the ICUs, and that too complicated infected situations. So it's a very innovative, different how to identify them. Identification is more important. So today's topic will be Dr. Jaya Banerjee is our microbiologist, consultant microbiologist. So she will be talking regarding the topic, and Dr. Monalisa Sahu, she is consultant ID specialist. She will be moderate the session. Yeah, Doctor, over to Dr. Jaya Banerjee.
Thank you, sir.
Yeah.
Thank you, sir. Thank you, ma'am. Good evening, sir. Good evening, ma'am. Good evening, all attendees. So I will start today. My presentation is on this drug-resistant bugs. So I am going to start my presentation.
Please close the PPT and reshare it again, ma'am. Please reshare the PPT.
This is one.
This was only one.
Yeah.
You want to open?
Yeah.
I think this one is.
This is one.
Hello. Yeah. Hello.
Sir, this is screen sharing is not happening anymore.
Yeah.
Doctor, I will be sharing your
Dr.
PPT. Just you take me to the slides. Doctor, we can start.
Yeah.
Just a minute, sir. Let me try because it's very small. It will be difficult for to describe actually. It's coming. Okay. Now I'm going to present that topic: the decoding of the resistant bugs, MDR, XDR, PDR, and MRSA VRE. This is very consistent with our today's scenario. So we are every day we are getting that MDR, XDR bugs. So before starting my presentation, I just would like to show this PP1 slide, where it is just a publication from the American Society of Microbiology, published in 2022, February only. So here they estimated that 4.95 deaths associated with the bacterial AMR across the globe in 2019. So it's considerably more than previously estimated. So they highlighted that it is the utmost importance is there for the antimicrobial susceptibility testing nowadays to prevent and managing the infections caused by the resistant organisms. So now data transparency and susceptibility testing is of the clinical laboratory are the utmost important now. Yeah, it's more than ever before. So starting with my presentation, this will be my contents, where I will try to inform antimicrobial susceptibility testing interpretation, not only just the interpretation, along with the which conditions, how the interpretation should be done, and what all things to be kept in mind during the interpretation, and the basic principles of antimicrobial susceptibility testing, of course. So starting with the antimicrobial susceptibility testing in the clinical lab is essential for patient care. So what are the basic principles of antimicrobial susceptibility testing to be perfect? So first of all, selection of the most appropriate antimicrobial agent consistent with the site of the specific site of the infection, and as well as the suspicion of the which organism can come. Secondly, the reporting and interpreting as per the clinical breakpoints. So clinical breakpoints are mainly determined by the minimum inhibitory concentration, that is called MIC, or zone diameter. So now again, MIC value can be calculated by microbroth dilution method or by yeast strips. So coming to the details on the pictorial presentation, here we can see the first one is this minimum inhibitory concentration, MIC value. This is normally what we do normally, here the microbroth dilution by the automated instruments, Vitek cards. But the basic principle is microbroth dilution only by the instrument is automated. Secondly, here that is a microbroth dilution we can do manually. In our laboratory also we do for the some particularly for the cholesterol. Here the disc diffusion method, here a zone of inhibition, that is this is the zone of inhibition and the zone diameter is calculated for the value of interpretation of the results. This is the another method is E-strip. E-strip we take for the, this is actually we do in the same Muller-Hinton agar what we use for distribution method by Kirby distribution method, but here we calculate the MIC values. So this that's why the MIC values can be calculated by E-strip, and secondly the microbroth dilution either by automated or by manual. Coming to next this few terminologies is very important for the interpretation. First is the clinical breakpoints. Clinical breakpoints is a discriminatory concentrations of the MIC or the zone diameter used to categorize an organism as susceptible, resistant, or intermediate. And what are the MIC values? MICs are the lowest concentration of an antibiotic which prevents the visible growth of a single isolate. Here in this is a report normally we get. So this is a blood culture report where the organism was detected as Klebsiella pneumonia. We have got this kind of, this is a report. So here all the antibiotic which we tested, it's given. And these are the groups. The antibiotics are given in the grouping this thing. Now here we can see here we have written result, that we have got that result in our automated system. So this result is called MIC value or minimum inhibitory concentration value. This is our result depending upon this organism, how it acts on this or how this bacteria, how these antimicrobial agents acts on this organism. This expected value, you can see, these expected values are actually the breakpoints. These breakpoints are, it can be susceptible breakpoints, this can be intermediate breakpoints, and this will be resistant breakpoints. So whenever we will get this kind of report, we have to see that this result, that is MIC value, is what is the correlation between this MIC value and the expected value. So this is the Klebsiella pneumoniae is coming to that cefepime. Suppose cefepime, this value is coming as 64, whereas here our resistant value is again more than 16. So more than 16 value, that is resistant. Coming to some, this is the, here also it is 64, cephalosporin sulbactam, it's coming as 64. If it is 64 in the resistant value, so it is, we will interpret as resistant. If it would have come around 16, then we would have told as susceptible. So these breakpoints and clinical minimum inhibitory concentration and clinical breakpoints together, we give the interpretation. This MIC or zone value, when paired, it's actually breakpoints vary from each antibiotic, and between it varies from the organism and organism to organism. Here in this slide, we can see here, this is a blood culture report of Klebsiella pneumoniae, where both amikacin and gentamicin are here, both are from the same group. But here these breakpoints are different, 16 and 4. Similarly, when this is a Pseudomonas report and this is a Klebsiella report. Here, for the meropenem, the breakpoints are for the meropenem. For the Enterobacteriaceae or this is Pseudomonas, it is 2. It is 2, whereas in the Enterobacteriaceae, it is 1. So breakpoints vary from the antibiotic to antibiotic, from organism to organism. And this MIC value or zone diameter value doesn't have any value individually. It's just a number for the clinicians. But when they paired together, they will give the information that helps to determine which antibiotic is the best for the patient. So we have regulatory agencies like CLSI, European Committee of Antimicrobial Susceptibility Testing, and FDA. We generally follow. Most of the countries are following this CLSI guidelines. European countries follow UCAST. So what are the CLSI looks like? From the inside, they gave this susceptibility and intermediate and resistant, these zones as zone diameter, and this for the MIC. So they are the breakpoints. When we get the MIC values from our organism isolates, then we have to compare with that and we have to give the interpretation result. Coming to interpretive category, we know normally susceptible, intermediate, and resistant. These categories are from the very beginning it's coming. So what is susceptible? When antimicrobial agent is clinically effective when used in standard therapeutic dose. Whereas in intermediate, maybe it is not working in the standard therapeutic dose, but when we increase the dose or frequency, it can be clinically effective. But here we don't know, we don't have any clinical trials yet. Resistant, when the antimicrobial is totally ineffective, even in the standard or increased dose. Now coming to a new terminology, susceptible dose dependent. It started from quite few years, just 2 to 3 years. So here it is almost just SDD. The short form we can call it as SDD. SDD is almost same as intermediate, but here the clinical effective when it is used in the increased dose or frequency. And the most important thing is the clinical trials already have been confirmed for the antimicrobial agent. Few antimicrobial agents have this SDD values. Here one report is there where the urine culture report, organism detected is E. coli. Here, this value, that ampicillin value is 32, and the breakpoint is the resistant breakpoint is also more than 32. So here we call it as resistant. Similarly, here in the BLBLI we can say, suppose let's say amoxicillin clavulinic acid. Here it is 8 is susceptible value, and here also it is given as the breakpoints is 8. So we can say it is a susceptible. Here the same here in this slide, I would like to inform that that intermediate and SDD values are the same, but only important thing is in SDD, the clinical trials has been done and it is proven that in the higher dose or the higher frequency, it will work. It is very limited for few antimicrobials. Here this is SDD. When the cefepime SDD, only it is available for the cefepime for enterobacterials group. It has SDD is available in 3 SDDs, kind of 2 SDD, 4 SDD, and 8 SDD. And according to this interpretation, we need to change the dose or frequency of the antimicrobial so that it will act as, it will effective. Here the values are given as susceptible, SDD, and resistant. In 2022, this SCLSI has been given the SDD value for piptas, piperacillin tazobactam also. So very few drugs are there with the SDD, but when the SDD are there, even if it is not susceptible, we can use with the dose frequency, increase the dose and increase the frequency as per the guidelines. Now, when the test isolate is susceptible to more than one antimicrobials of the similar spectrum, how to choose the most appropriate antimicrobial for directed therapy? Here the therapeutic index comes. Therapeutic index is nothing but susceptible breakpoint divided by the minimum inhibitory concentration of the test isolate. So whenever the therapeutic index is the higher, that will be considered as more effective. Here in this report, I will tell that urine culture report the organism came as coli. Now here all these things we will not prefer because these are resistant. But in this case, these are susceptible that pick up for the treatment. Now, which one we should use? Here, if we see here as a arbitrarily, we can see here that is these other MIC values are less. Okay, fine. But in BLI, which one we will prefer? We will prefer because this MIC, these are already I told this result is MIC and this expected value is breakpoints. Now, the MIC values of 8 piptas and amoxiclav is lesser than the cefzolbactam. Then is it better than this? So let us calculate the therapeutic index. Here, this susceptible breakpoint is 8. Here, MIC is 8. So 8 divided by 8 is 1. In amoxiclav also, 8 divided by 8, 1. Whereas ceftazidime sulbactam, 16 divided by 16, 1. So all three are therapeutic index therapeutic index same. So they may be similarly effective. In case of carbopenium, the susceptible breakpoint is 1 divided by MIC is 0.25, so it is 4. Similarly, meropenem is also 0.4, whereas ertapenem is 0.5 divided by 0.5, so 1. In case of amikacin, susceptible breakpoint is 16 and susceptible MIC value is 2, so it's 8. If we see here, that is apparently can be visible that these values are, carbopenium is more effective, but here amikacin, the therapeutic index is high. So it could be preferred for therapy unless and until the other indications are not there. Here is a good example. Here they have given the therapeutic index. Organism reported as Klebsiella pneumoniae. Amikacin is MIC value is results as 2. Meropenem is 0.5. So apparently we can tell that this amikacin and meropenem, so that meropenem is the much better drug because it has a less MIC value. But if we go through this susceptible breakpoint, amikacin has a higher susceptible breakpoint. So when it comes to the interpretation, it will come as 8. Whereas meropenem, the therapeutic index comes as 2. So in reality, the amikacin is more effective as having the higher therapeutic index. Apparently, although apparently meropenem appears to be more effective. Coming to resistance. Intrinsic resistance, we have intrinsic and acquired resistance. So intrinsic resistance is the innate ability of the bacteria to resist the action of an antimicrobial agents, and they are from birth. So it is so common, this intrinsic resistance. So susceptibility testing is not required to not tested. Those antimicrobial agents and need not to test also. Now coming to acquired resistance is phenotypic resistance and genotypic resistance. Normally what we do, we report the automated or by conventional method, the phenotypic resistance. When we want to find out the gene responsible for resistance development, then we go for genotypic methods like molecular methods, expert CARBAR or field array. So coming to the intrinsic resistance, many intrinsic resistance examples are there. Many are there. A big list is there, but we cannot define all this. The few basic important things I have written here. First is the Enterobacterials group, Enterobacteriaceae group. Now it is known as Enterobacterials. So Enterobacterials, all Enterobacterials should not be tested for clindamycin, daptomycin, glycopeptides, basically all the GPC coverage drugs and macrolides except Salmonella and Shigella, which are susceptible to azithromycin. Now coming to Klebsiella pneumoniae, of course, all these above drugs are intrinsic resistant, and apart from that, ampicillin and ticagrelin is also resistant for Klebsiella pneumoniae. Non-fermentous GNB. Here the penicillin, cephalosporin group 1, 2, and kefamycin, all GPC coverage drugs are intrinsically resistant. Pseudomonas aeruginosa, being a non-fermenter gram-negative bacilli, definitely it will, all these drugs also, the above drugs are also resistant, intrinsically resistant. Apart from that, Pseudomonas aeruginosa is intrinsic resistant to ertapenem, tetracycline, TG-cycline, minocycline, cotrimoxazole, and chloramphenicol. Similarly, Acinetobacter baumannii, apart from all the above drugs, it is resistant to amoxicillin, ampicillin, amoxiclav, ertapenem, aztreonam, chloramphenicol, and phosphomycin. It is important, phosphomycin also. Protea tribe means Proteus, Providentia, and Morganella. They are in Enterobacterials group. So they are also resistant to all the drugs which are common for Enterobacterials, plus ampicillin, first and second generation cephalosporins, tetracycline, TG-cycline, nitrofurantoin, and polymyxin. Here, one important thing is for Salmonella and Shigella. Here, this is not totally the intrinsic resistant, but it is the warning. Aminoglycosides and first and second generation cephalosporins and cephomycins may appear active in vitro, but when we will give the in vivo, it will not be effective clinically. Citrobacter and Enterobacter species are also enterobacterials. So apart from the enterobacterials resistant, intrinsic resistant, the first and second generation cephalosporins, amoxiclav, ampicillin sulbactam are the inheritant resistant. For gram-positive bacteria, including the Staphylococcus aureus, here the azithromycin, polymyxin B, colistin, and nalidixic acid, we should not taste as we should not be tested because they are intrinsically resistant. Coming to most important for the GPC drug is the Enterococcus species. Above these drugs, plus all cephalosporins, aminoglycosides, clindamycin, and cotrimoxazoles are intrinsically resistant to Enterococcus. Coming to this point, polymyxin B and colistin are inherently resistant for few groups such as Protea group, including Proteus, Morganella, Providentia, then Serratia marcescens and Stenotrophomonas multifolium, and Percoldaria cepacia complex. This is interpretation of an antibiotic susceptibility test report. This we used to get this kind of reports long back where most of the drugs were susceptible. Only a few, one or two are resistant. But now we are in the era of MDR, XDR, or PDR. So from these results, we can find out what are the MDR, XDR as a basic, as a standard report. I would like to define the MDR, XDR, and PDR one by one. So coming to the next slide. Here, this is a report where we get the urine report, urine culture report, E. coli. Here, actually the MDR defined as acquired resistant to at least one agent in three or more than three antimicrobial categories. Here, if we see here, here one group is ampicillin, is penicillin group. Here, this group is cephalosporin group is second group, and the third group is here the ciprofloxacin, that is quinolones group. Nitrofurantoin is also resistant. Here is the fourth group. So here we can say it is a MDR. Although the carbopenium is sensitive, but the other four groups of antimicrobials are resistant. So we can categorize it as MDR. So, but here we have option to choose some BL-BLI combination for therapy, directed therapy, or carbopenims, or the amikacin, gentamicin like aminoglycosides, and even cotrimoxazole is also sensitive. Then they're coming to the XDR, how the AST report of the XDR bugs look like. So what are the XDR? These are the acquired resistance to at least one of the group of the drugs for almost all except one or two group of drugs. Here, if we see here, almost all are resistant. It's a blood culture susceptibility, blood culture and susceptibility report where E. coli grown in culture, and almost all are resistant. Even carbopenium is also resistant, and only sensitive to amikacin, gentamicin, that is aminoglycosides. So these are particularly called as carbopenium resistant enterobacterials. Here, colistin is intermediate. Always we found the colistin as intermediate since 2019-20. So coming to this here, we can utilize this and according to the clinical condition of the patient. Next is the XDR Carbopenium resistant enterobacterials. This is another XDR pattern where it is urine culture, E. coli is there, and here the E. coli is also E. coli, and almost all are resistant except aminoglycoside group and nitrofurantoin, because it's a urine culture, so we use nitrofurantoin for the. So these two groups are there sensitive. Apart from that, all are resistant. So we can call it as XDR, extended drug resistant organism. Coming to XDR Carbopenium resistant Acinetobacter baumannii complex. It's a very common nowadays. Here we can see here is a tracheostomy secretion culture, and Acinetobacter baumannii complex has been detected. So all groups are resistant. The aminoglycosides also resistant, quinolones, all are resistant except TG-cycline. TG-cycline is sensitive and colistin is intermediate. However, we give colistin as intermediate, we cannot write as sensitive. So here the immunocycline also we have reported, but here nothing much is there, only colistin along with TG-cycline can be a therapeutic option. So whenever we get this kind of resistant pattern, we try to add some more, we try to test some more antimicrobials, antibiotics like minocycline. So if it is sensitive, that also can help along with the colistin, the dual therapy with the colistin. Now this is XDR Carbopenium resistant Pseudomonas. Here ET secretion culture has been sent, and we got Pseudomonas aeruginosa, which is almost resistant to all the drugs except aminoglycoside. These are the very common nowadays we are getting. Cefepime is anyway intermediate. So in this case, only options will be again the aminoglycosides and colistin, which is intermediate. Coming to Staphylococcus aureus or sensitive, methicillin sensitive Staphylococcus aureus. Here in this report, blood culture report, we received MSSA, that is Staphylococcus aureus, methicillin sensitive Staphylococcus aureus. Here two things are the marker where the cefoxitin screening, it should be negative for being MSSA, and oxacillin should be susceptible, less than 0.25 mg for being a methicillin sensitive Staphylococcus aureus. Now, if in case, and here in this, the other antimicrobials are tetracycline, vancomycin, linezolid, teicoplanin, all are susceptible. So once this is MSSA result, the anti-staphylococcal beta-lactam sensitive, so they are the much superior the vancomycin. We should not start with vancomycin treatment. Here the one more important thing is inducible clindamycin positive. Once the inducible clindamycin is positive, we should not be given for serious skin and soft tissue infections, as resistance is likely to develop during the long-term therapy. Coming to MRSA, methicillin resistant Staphylococcus aureus. Here the Staphylococcus aureus is again cefoxitin screening is positive and oxacillin is more resistant. So here in this case, these are all are susceptible. For MRSA, oxacillin and cefoxitin, all beta-lactams must be avoided because beta-lactams are resistant. So here the drug of choice may be vancomycin. And MRSA, if in case of MRSA, if vancomycin susceptibility, here in this case, we can see in this report, we can see vancomycin is 1. So that is the MIC value of vancomycin is 1. If it is 1, then it is fine. But if it is more than 1, because our susceptible breakpoint is 2. So we consider if 1 is susceptible is MIC, then it is fine. But it is more than 1, therapeutic failure chances are more, even if it is susceptible. Coming to Enterococcus species. Enterococcus species here, this is the sensitive strain where we got, it is an again blood culture, Enterococcus specium detected. And here the synergistic resistance is there, that is synergistic high level gentamicin. But here the vancomycin and linezolids are susceptible. Vancomycin, teicoplanin, linezolids are susceptible. These are sensitive strain. On the contrary, here again the Enterococcus faecium, again the synergistic resistant is there, synergism is there, resistant is there, but here the vancomycin is resistant and teicoplanin is resistant, so it is vancomycin resistant Enterococcus will be considered. In both the cases, high level gentamicin synergy is resistant. That means already we discussed that Enterococcus are resistant to Enterococcus are resistant to gentamicins, aminoglycosides, but high-level gentamicins can be used for the synergistic effect along with the other antimicrobials like ampicillin and penicillin, which can penetrate through the cell walls. But in these two cases where the resistance is there, we should not use the drug high-level gentamicin along with the synergistic effect with ampicillin. Now coming to the pan-drug resistant organism. Here in this report, we got the aerobic blood culture where Klebsiella pneumoniae we got. Here all the drugs are resistant. Here the cholesterol is although intermediate, but it's not sensitive. We cannot consider it as a sensitive, so we can consider it resistant. Sometimes we get the cholesterol also resistant. That is also definitely the pan-drug resistant organism. Here one more example where that is the blood culture and Klebsiella pneumoniae. Again, we isolated, but here all are resistant. In that case, what to do? We have additionally, we have tested the fosfomycin. Luckily, that was sensitive. So at least one or two drugs we got for the treatment. This is the Pseudomonas aeruginosa, again the almost pan-drug resistant. All these drugs are resistant, although cholesterol is intermediate, but sometimes cholesterol also sensitive. That time there is the only option is the therapeutic option is ceftazidime avibactam with or without the aztreonam, depending upon the gene detected by the molecular method or conventional. So here what are the use of ceftazidime avibactam? In the breakpoints of ceftazidime avibactam are also mentioned in CLSI 32nd edition, this 2020. Although there is a breakpoints based on a dosage regimen of 2.5 gram every 8 hours, administered over 2 hours. If OXA48 or KPC is identified, we can give directly the ceftazidime avibactam. But if NDM is NDM detected or NDM with OXA48 co-production is there, then ceftazidime avibactam cannot affect. So aztreonam has to be paired with the ceftazidime avibactam, because aztreonam is the only beta-lactam inherently impervious to MBL. From this picture, we can see ceftazidime avibactam can be effective against ESBL, AMC, KPC, OXA48, but it cannot penetrate NDM, where the aztreonam works. Aztreonam can impermeable the NDM part, and it can ceftazidime can act. Ceftazidime avibactam can act. So here is an antibiotic depending upon the genotype. Always before ceftazidime avibactam starting, we should find out the gene either by expert carbar, where the genotypic detection of the detection of the bacterium gene, that is OXA48. In this case, here it is from the Klebsiella pneumoniae detected from the bronchial wash. Here, when we did expert carbar, it came as a OXA48, whereas in this, the co-production of NDM and OXA48. So according to this report, we can give ceftazidime avibactam alone or can be given by aztreonam. An interesting strategy to overcome the beta-lactam resistance confirmed by the metallo-beta-lactam is the Enterobacterales is the zone of hope. This is a zone of hope. This is a ceftazidime strip, ceftazidime avibactam strip, E strip, and this is a aztreonam. This is called, this is a synergy. This ceftazidime avibactam strip may be alone it is resistant, and aztreonam it may be resistant, but when they pair together, they cause a synergistic effect that will be helpful in predicting that ceftazidime avibactam with aztreonam can be effective clinically. Here, in case of Pseudomonas, ceftazidime avibactam and aztreonam both are not showing any zone of inhibition, common zone of inhibition. So they are individually resistant, and with the synergistic effect also, they will be resistant. There will be no synergistic effect. Together, they don't have any synergistic effect. These are the few slides where the few cases where here ceftazidime avibactam alone, this is E-strip alone, it gives a good MIC value, and we can predict that ceftazidime avibactam definitely will work clinically effective. Here also it is totally resistant. Ceftazidime avibactam alone cannot be effective. Here in this case, ceftazidime avibactam and aztreonam, they are individually also sensitive, but together also sensitive can be given. Along with ceftazidime, maybe ceftazidime avibactam can be given alone also in this case. Here in this second slide, ceftazidime avibactam alone is resistant, whereas aztreonam is alone also resistant, but the synergistic effect is there, synergism is positive. So with the combined CZA and AT can be given. Here in this case also, CZA is individually resistant, but with aztreonam, it gives the synergy may act clinically. Here also CZA and aztreonam is a very good, so CZA alone also is sensitive, and synergy is also there. Depending upon the clinical condition and clinician's decisions, CZA, ceftazidime avibactam can be given alone, or ceftazidime avibactam along with aztreonam to be decided. At the last, we have to follow the 90-60 rule always. That is what to do if the isolate is resistant to all the antimicrobials tested. So susceptible infections respond to appropriate therapy approximately 90% of the time, whereas the resistant infections also respond only 60% of time. So patient-specific and pharmacokinetic factors have significant weightage in determining the clinical success. Although it is in vitro, but in vivo, it works nicely. Therefore, antimicrobial with resistant results can still be considered for the treatment when the organism is resistant to all antimicrobials tested. However, resistant antimicrobials should not be given for the treatment when the antimicrobials with susceptible results are available. These are my references. Thank you. If any questions?
Yeah, thank you. Good evening, friends, and thank you, Dr. Jaya Banerjee, in bringing this updates on assessment of antimicrobial susceptibility of the different bugs. Today, we are actually discussing one of the important topics in modern medicine, where I think in no less than 100 years, we are losing the battles to the microorganisms whom we actually found an answer almost 70-80 years back by in the initial days of Alexander Fleming's penicillin. So we are in an era where our battle for it, or the weapons for this battle, are slowly getting wiped up by these microorganisms. So many clinicians in our clinical rounds in different organizations, I realized that the interpretation of MICs, when we get a report, suppose from the blood or ET secretions from the urine or any of the specimens, they look at the MICs. And once they find a MIC which is lesser than the others, they find that antimicrobial is probably the best, irrespective of other points which we mentioned. So this has been a common observation which I had across the last 15-20 years. So the way the clinicians look at MIC is looking at the MIC which are the least considered to be the best effective antimicrobial because it works with a lesser concentration. But as you highlighted, few points that the breakpoints for that particular antimicrobial is important. And also you spoke about so the MIC linking with the breakpoint, getting the index. So what is your take on that? So how do a clinician should interpret a report when he gets a report about any of their samples which are sent for you? Once they get the report, how do they interpret these MICs?
So first thank you, sir. First we should we should check the MIC, what we have given the result. That is the actually MIC value of the organism, which got that organism isolate that we got from our report, we got from our test. So that will be the MIC value. Whereas in the right side, when the susceptible and resistant and intermediate, those values has been given, those are the predetermined ranges. Those are called the breakpoints. So always we should check our MIC values is either less than the susceptible range of the breakpoints or more than the susceptible range of the breakpoints, or it comes in the in between. According to that, we are giving the interpretation. So we can interpretive categories, we can see the sensitive, resistant, or intermediate. Coming to the therapeutic index, here once the clinician has checked the interpretation, now he has to find out the which antibiotic to be used. If more than one group of drugs are susceptible, then the therapeutic index comes, sir.
Yeah, so what happens is if a drug is resistant, it is out. Suppose
Yes,
we
sir.
have multiple antimicrobial which are susceptible in different classes.
Yes.
Suppose carbopeniums are also susceptible, and in the same time, maybe aminoglycosides are also susceptible, and BLBLs are also susceptible. So when these are the drugs which are susceptible, and I see both MICs and, as you said, the cutoffs, breakpoints, susceptible breakpoints, intermediate breakpoints, resistant breakpoints, which are predetermined and given by the bodies like CSI or UCAST from either West groups of United States or Europe. So accordingly, you decide on that. That's what you're trying to say.
Yes, sir.
So the message is clear. When you interpret or when you try to interpret a antimicrobial susceptibility report, it needs to be correlated, not just with only one MIC, but the correlation has to happen with the breakpoints which are given next to the susceptibility cutoffs or susceptibility MICs. So the ratio which is taken along with the breakpoint will probably give us a better way of interpreting this.
So higher the therapeutic index, the more effective the drug. So susceptible breakpoints divided by MIC value is the therapeutic index. And we always, we should go by lower antibiotics, and then we should go for the BLBLI combination or carbopeniums and reservant like antibiotics.
There are some questions from the audience. The therapeutic index has also been used when we say the safety margin index, when you have actually the lethal dose to the therapeutic dose. I think we are only talking about the antimicrobial.
It's different from the other. It's only for the interpretation and the effectiveness of the antimicrobials to be used.
So this always need to be correlated with your breakpoints, and that probably will give us the idea. Yes. So the other thing which you added right now is SDD.
Yes, sir.
So we earlier were aware that every antimicrobial will have a three kind of interpretation: susceptible, intermediate, or resistant. Yes. Now, what is this SDD?
So earlier was susceptible, intermediate, and resistant. Three are there. But the intermediate, so this susceptible dose dependent, SDD means susceptible dose dependent. It's a kind of intermediate only. But the thing is, in the intermediate, it was defined, intermediate category was defined as that the antimicrobial is not effective clinically in the standard therapeutic dose. But when it is either dose is increased or frequency is increased, it can be effective. But it can be effective. It was not clinically established. Clinical data was not there. But in case of susceptible dose dependent, the same intermediate group, but the clinical trial has been done, and it is proven that yes, these drugs are, if we give in a higher dose or higher frequency, then it will work clinically, it will be effective. So the only difference between intermediate and SDD is that clinical trial is there, and very few drugs actually SDD has been established, very few drugs.
If the susceptibility range of breakpoint is less than the corresponding MIC, what does it mean?
Susceptible?
Range of breakpoint is less than the corresponding MIC. So I think that means
that will be sensitive. That will be sensitive, susceptible only.
Ma'am, if breakpoint is not given in many of the reports, so we need to ask for a.
Yes, sir. Ideally, if now it's not like microbiology is the laboratory microbiology, it should be clinical microbiology in the era of this MDR HDR bugs. So these breakpoints must be given. It is otherwise it is very difficult to treat the things. We cannot get the proper therapeutic index and proper MIC values. So the breakpoints we should ask.
So the breakpoints only can give you that probably appropriate therapeutic index, which can guide you,
Yes.
not just sensitivity or MIC values. Can we always use a therapeutic index? Is it helpful in antimicrobial stewardship? I think I will add on here, therapeutic index may give you the susceptibility pattern, but again, it need to be in the clinical context. Sometimes you may have a great therapeutic index, as we see aminoglycosides of amikacin having a therapeutic index of 8 over a meropenem whose therapeutic index was 4. But I will look at if my patient has a bacteremia, if my patient has other than urinary tract infection, what is my site? Is the drug penetrating to that site? How safe is the drug? Is there any contraindication or collateral damage this drug can cause? So your clinical context do play a role. We are talking about beyond clinical context, this susceptibility reports, which from breakpoints with the therapeutic index can add. Suppose you have a good therapeutic index drug and you have a good penetration, and it can actually clear the desired disease, then probably you can offer that. But always these all therapeutic index breakpoints or the MICs need to be considered in the clinical context without taking into the source, without taking into the drug penetration, without thinking about the toxicity related to the drug in your clinical practice. You cannot just blindly follow one. All has to be taken into account in them. So how can we decide breakpoints in various fluids? There was a discussion like you have a breakpoints and how you actually decide on. That's what I was actually just pointing out. Dr. Monalisa, you wanted to get into it, like the different fluids like CSF, blood, urine, and maybe bronchoalveolar lining fluids and all. You can unmute, ma'am.
The breakpoints are like for different sets of organisms and different drugs. It is not like in the different fluids like that MIC will vary. It is the drug and bug combination, but not in the different fluids. It is the MICs will remain the same. But we need to take into consideration whether the drug penetrates into that site where our site of action is intended. So the MICs will not vary, but we need to take other factors into consideration, like the pharmacokinetics and the pharmacodynamics, the penetration of the drug into that site, etc.
Ma'am, nowadays we are seeing more of colistin intermediate. We have not seen for the last 3 years colistin being sensitive. We get to know from the microbiology department, we have new CLSI guidelines that colistin no more be given as a sensitive. It will always be given as intermediate now onwards. So can you just throw some light on that? I can see all your reports as intermediate only.
Yes, sir. Actually, until 2019, CLSI guidelines was giving as the my MIC value of colistin less than 2 is sensitive only. But from 2020, they have given as, we cannot write it as sensitive. We have to, it starts from the either intermediate or resistant. So because it is the PKPD data has shown that it has a very limited efficacy of colistin or polymyxin. So it should not be used as a monotherapy. So if we give the sensitive, we can do the sensitive monotherapy can be given. So just to discourage the monotherapy, we can add something. That's why it is the intermediate they have given. Moreover, one more point, if the colistin is systemically given, for the pneumonia, it will be not at all effective. So many conditions are there that shows the colistin is not very much effective either monotherapy or very much limited clinical efficacy. So they have given the intermediate. They have not put any sensitive value. So only the resistant values they have given.
What is your take, Dr. Monalisa? We all been using colistin for the last, maybe at least the last 15 years. So now we are looking at little warning signs about colistin, saying, be careful, don't report it as a sensitive at all, just to avoid the misuse or all that.
Yeah, the CLSI came up with the change in the guidelines in the 2020 that the colistin needs to be reported as intermediate or resistant rather than sensitive. It was mainly to discourage the use of monotherapy of colistin, as there are a number of adverse effects associated with it, as well as the pharmacokinetics and pharmacodynamics of the colistin are variable, not very predictable, and also to colistin sparing therapy is essential. We need to consider other drugs due to the various adverse effects of colistin.
So there are questions related. We will first take, is intermediate drugs should be avoided in treatment? Dr. Jaya Banerjee.
Yes, sir. If intermediate drugs, the other options are there where the susceptible drugs are there. So always we should prefer the other drugs. Now coming to intermediate drugs, if it is only intermediate, always we should avoid if the others sensitivity is there. But if in case of SDD, we can easily use this with the proper dosage and frequency, increase in the frequency. But in case intermediate, if it is towards the zone sites, it is not more towards the sensitive breakpoints, the intermediate range is there, but the intermediate value is towards the susceptible zone breakpoints, then we can use if the other options are not available. But if it is more than resistant side, we should not use.
So it is again clarified that if we have a better options in the form of sensitive drugs, you can always choose them. Many of the times we land up in a situation where none of the other drugs are available. And then there is again a word called SDD. If you are in the SDD, you may probably can use in a higher frequency, in a higher dose. But if you do not even have a SDD, then you have left with only the intermediate drug. Probably you can try with a higher dose in combination in a higher frequency with other things which probably. So there are some questions. I think even in spite of repeated emphasis, there are still doubts. What is the difference between a minimum inhibitory concentration, that is MIC, and a breakpoint? Dr. Jaya Banerjee.
So minimum inhibitory concentration is just the lowest dilution where the bacteria does not grow. This is the inhibitory power. And the breakpoints is a predetermined range, which is guided by the clinical various pharmacokinetic data, clinical data, all those, where these are susceptible points, where these are for comparison with the MIC to get the interpretation and to categorize the organism or isolate as sensitive, as resistant, intermediate, or susceptible, dose dependent. So there is none of them, the MIC value or breakpoints alone, they are just a point, they are just a number. But when they pair together, they are the help, just the max help to find out the maximum best treatment for the patient.
Ma'am, coming back to the Dr. Monalisa, ma'am, see, most of the times we get this kind of reports, and many of our centers may not have availability of what phenotypic or genotypic mapping in many of them. So how from a report, from a point of report, suppose I get a report, from that I will suspect the possible mechanism of resistance. And from there, I will probably interpret these are the possible resistant mechanisms. Can you just inline run on that? Before we go to the CARBA or before we go to the genetic testing, from the report itself, from the susceptibility and resistance, can we get some idea about what are the possible resistant mechanisms in that?
Looking at the reports, we can have a clue whether to what is the resistance mechanism of the bug. Like I would like to illustrate with an example.
You can share your slide.
Yeah. Can you see?
No, please share your slides.
Okay.
So,
now can you see?
No. Yeah, we can see.
Yeah, like as you can see, like with the report, there are like several mechanisms of resistance, like the production of the beta lactamases. Like the penicillinases are the ones when they are produced, the organism is resistant to the penicillins. When it is resistant up to the third generation cephalosporins, we can suspect that it would be an AIIMS, the mechanism of resistance genes. And if it is resistant to all the 4 classes of cephalosporins, it can be suspected to be an ESBL. And in addition to that, if it is also resistant to the carbopenims, it may be due to the production of by the carbopenimases, which is again further of 4 types and 4 classes. And the most common ones in India are the NDM, the metallobetalactamases, the OXA 48 being the commonest, and the KPC, which is less common in India. And the other OXAs like the 23, 24, 25, 51 and 55, which are more common than Acinetobacter.
So what are the common resistant mechanisms? See, right now in many of our ICUs, we come across most common 3 gram-negative bacteria. If we level it, they were Klebsiella most of the times, and then followed by maybe Pseudomonas and Acinetobacter, and some of the urine samples can be E. coli. So what is your take when a patient in the intensive care unit or in a hospital gets this kind of bugs? What are the most common mechanism of resistance in these kind of thing? If we classify them, we say CRE, that is Carbapenem resistant Enterobacteriaceae family, and then we say Carbapenem resistant Pseudomonas aeruginosa, and we say Carbapenem resistant Acinetobacter. So we are only focusing on Carbapenem resistance because that has been one of the leading problem for many of our intensivists. So what are the different mechanisms we suspect is been very common in many of these isolates?
Yeah, as we know that the carbapenemase resistance is much evolving, and many of the isolates are resistant to the carbapenems. Mostly it is by the production of the carbapenemases. The most common mechanism of resistance in the Enterobacteriaceae family, the CREs, is by the production of carbapenemases. And amongst the E. coli, the OXA 48 is the commoner one, followed by the NDM. And in the Klebsiella, it is the OXA 48, which is more common. And in India, we see the combination of OXA 48 as well as NDM in many of the cases. For the case of Pseudomonas, it is the metallobetalactamases which are commoner, but also they have the other mechanisms of resistance like the porine channel loss and the efflux pump mechanisms, and the other enzymes like the PER and Web, which are the additional resistance mechanisms by the Pseudomonas. And for the Acinetobacter, it is the non-OXA 48, like the other OXA, which is OXA 23, 24, 51, and 58. So, as we know that the drug Cas-AV is effective only against OXA 48, so we cannot use in the case of Acinetobacter.
Okay, ma'am. Okay, ma'am. So just to re-emphasize, I think she has pointed out the Enterobacteriaceae family. It is a combination of carbapenemase producer both OXA and NDM with add-on some other, but these are the common ones. But for Pseudomonas, this may be NDM and the other 2 variants. Whereas in Acinetobacter, OXA 48 has not been very common. So we see other OXAs with NDMs. So, ma'am, many of the times we do get an idea from your lab reports. You actually gave a flow that if you have a carbapenem resistance, you do suspect these things. There were some questions in the chat box which I saw. You may sometimes see the patient is resistant to carbapenems and sensitive to one of the BLBLIs. And we also see that this kind of things when all the antimicrobials are resistant, you may have a susceptibility to one of the aminoglycosides, or sometimes nitrofurantoin, sometimes maybe cotrimoxazole. So what is your take? What we take from those kind of combination? We do understand when you said penicillin resistance, we get some information. Cephalosporin resistance, we get some information. When we see the 4th generation cephalosporin resistance, we get an ESBL. And when we get a carbapenem resistance, we get this information. But when it happens haphazardly, jumbly, what are the other possibilities which we get?
So what I believe that when we get that this kind of reports that aminoglycosides are susceptible or the nitrofurantoin are susceptible, whereas the carbapenem is resistant. So possibly the patient is a chronic patient or admitting to the hospital many a times, or sometimes like their own medications. So they are creating the unnecessarily selective pressure for the particular drugs. So that can be a possibility, particularly when the chronic patients repeated admission in the hospitals, ICUs. This carbapenem, particularly the meropenem usage are more. So maybe because of that, those antimicrobials which are untouched still, so those are giving the sensitive pattern, whereas those are unnecessarily used. Those are because of selective pressure, they are getting the resistance more often.
Dr. Monalisa, do you think the efflux pump or pouring channels may play a role there?
Yes, sir.
The Carbopenium resistance is mostly by the carbopenimases, but there are other mechanisms also, like loss of the pouring channels and efflux pumps. So when we see that it is a Carbopenium resistant but sensitive to the like BLBLI, it can be due to the non-carbapenemase production, like the other mechanism reactions could be playing a role.
So most probably this kind of that carbapenemase producing is a genotypic resistance. So apart from the genotypic resistance, the other phenotypic resistance, those are common in those cases, particularly these pouring channels.
So,
and those are the phenotypic.
How reliable we are in actually treating those bugs, Dr. Monalisa, with those kind of things? Suppose I get a patient whose Klebsiella is resistant to carbapenem but sensitive to beta-lactam lactamase inhibitors. So how reliable those reports to treat them? Are we rely that these are all pouring or a flux mechanism and we can treat them, or we need to keep an eye on the clinical improvement also?
We should be like taking everything into context, like the condition of the patient. If he is hemodynamically stable, then we may go with the BLBLI and not complicated infection, maybe only a UTI or something, uncomplicated UTI, and we get a bug which is sensitive to the BLBLI but resistant to the carbapenems, we may go with the BLBLI. But if the patient is hemodynamically unstable along with severe infection and other parameters like lab parameters worsen, then we may prefer using the other drugs rather than going with the BLBLI.
So when do you order a carbar?
When we get a carbapenem resistant bug and an HDR, then to know the mechanism of resistance, like which genes are responsible, and to select the appropriate drug, we need to order an carbar. And it is mostly helpful in the cases of the Enterobacteriaceae, as the mechanism of resistance is mostly the carbapenemases in them. But for Pseudomonas and Acinetobacter, we have got other mechanisms of resistance which are not included in the carbar test. So they may not be very helpful in the case of Pseudomonas and Acinetobacter, but for the E. coli and Enterobacter and Klebsiella, these may be helpful.
So now the core question: suppose you have a bacteria, and which is a carbapenemase resistant Enterobacteriaceae family. Suppose I mean carbapenemase resistant E. coli. Okay. On different organ system wise, how will Dr. Monalisa manage them? So we have a carbapenem resistant E. coli in urine, E. coli in blood, E. coli in GI tract or an abdomen. So what will be your choice of antimicrobial in a E. coli and Klebsiella?
In case of a E. coli, like if it is an urinary tract infection, complicated urinary tract infection, carbapenemase resistant, we may use therapy like Cas-IV with Astronam if the resistance mechanisms is detected by the expert carbar, or we may go with the fosfomycin along with the colistin if it is a severe complicated UTI. If it is in the case of bone infection like osteomyelitis, we may go with the fosfomycin along with the polymyxin B or Cas-IV with the Astronam. And for in case of the blood infections, we may go with the Cas-IV with Astronam or the other drug like if not available, then we may go with the polymyxin B with the fosfomycin.
So actually categorize them. You get a carbar report which says either you have a OXA, NDM, VIM, IMP, or sometimes which are non-carbapenemase producers which are not been known to you. So this is the information which you'll get. Now you say whether it is a CRE or a carbapenem resistant Pseudomonas or carbapenem resistant Acinetobacter. Now we are dealing about the therapy. The therapies again, as you classified, are into two categories. One is either polymyxin based categories. The other one is non-polymyxin based categories. When we actually discussed about E. coli and Klebsiella in different system wise, you try to prioritize one over the other. Is there any reason to prioritize one over the other? Polymyxin based therapy, non-polymyxin based therapy?
Polymyxin based therapy should be the second line for the cases of Enterobacteriaceae, as many studies have shown that the polymyxin B pairing therapy is helpful in the case of the enterobacterials, whereas for the Pseudomonas and Acinetobacter, the polymyxin B or the colistin forms the backbone.
So you mean to say non-polymyxin based therapy will be probably the first priority or the first choice over the second? And when you said E. coli, you had options between both Ceftazidime avibactam combined with azitrona, because if you have, again, depending on your probably
The
Carba report,
mechanisms.
Carba report, if you have only Oxa alone, you can still go along with only with Ceftazidime avibactam alone, not combining with anything else. But if you have a NDM or any other mechanisms adding to OXA48, probably you need to combine azithromycin. And you said you will prefer there over the E. coli. Will it differ to a Klebsiella? You said for E. coli, urinary tract, you used fosfomycin, or alternatively, you said I can use ceftazidime avibactam along with azithromycin depending on resistant mechanism. But what about the Klebsiella pneumoniae, which is more common than E. coli? In lung, we see VAPS with Klebsiella pneumoniae, we see CRBSI with Klebsiella pneumoniae. So what will be your choice in Klebsiella? Will it differ or it will be same?
In Klebsiella, the OXA48s are the most common resistance mechanisms we see in most of them. And the drug Cazavi has been shown in multiple studies to be having better action on the Klebsiella. And with also lower mortality rates when compared to the polymyxin based therapies. So for Klebsiella, the drug of choice would remain Cazavi.
But many of the times, Dr. Jaya, many of the times what we clinically observed in our institution is the co-production of NDMs has been very, very common. And single resistant mechanism like oxapatite has been not as common as it been reported in many literatures.
Yes.
So in those situations, what will be an empiric therapy and how will we de-escalate? And will you prefer any particular site over the other? Like you have, as I said, lung, and you may have blood. And these are the most two common things which we get as a nosocomial infection, and sometimes urine. So Klebsiella pneumoniae, if we come across Dr. Monalisa, what will be your choice in these three sites?
Klebsiella pneumoniae, if there is a combination of both OXA48 as well as NDM in the blood and also for the lungs pneumonia, it would be Cazavi with Astrona. And for the urine also, it would be, if it is a complicated UTI, then we would prefer to go with Cazavi with Astrona.
Monotherapy, or that means I believe that ceftazidime avibactam plus azithromycin, we put them onto one single drug. Will you use a single drug in that way, or you will try to use a combination drug?
If it is like therapeutic response is not obtained within about 48 hours of beginning that, and then we may go for further, like thinking about the other mechanism of resistance which could be present, which are not detected in the expert carbar, we may add on polymyxin based therapy along with that polymyxin.
So the summary of discussion till now is, if I have a patient with an Enterobacteriaceae grown, which is a fermenter, and that is either E. coli or a Klebsiella, I will try to choose a non-polymyxin based therapy as an initial choice. And then if it is not getting better, I probably will consider a combination, and my polymyxin based combination therapy will be my second line. If we come to the next one, Pseudomonas. So what we have seen, ceftazidime avibactam being a useful drug, and has been successfully proven to be more effective than colistin, which we all know been an old drug and has a very slow clearance of clinical and microbiological, has not shown to be the similar way in Pseudomonas when it comes to ceftazidime avibactam's role in Pseudomonal infection. What do you think the main reason why it has not been as effective like Enterobacteriaceae in Pseudomonas? Dr. Monalisa.
The Cazavi, like there are multiple mechanisms of resistance with the Pseudomonas, not only the OXAs and the NDMs, but the other mechanisms like the loss of porine channels and efflux pumps, and the other mechanisms like the production of PER and web enzymes. So these all are not taken care of by the Cazavi. So in this case, the polymyxin B and the colistin remain the backbone. And in case of urinary tract infections, the colistin would be preferred over the polymyxin B, whereas in all the other sites of infection, the polymyxin B would be preferred. due to its better pharmacokinetics and lesser adverse drug profile.
So when it comes to Pseudomonas, you will be more cautioned, looking at what kind of mechanism is it? Is it NDM or is it OXA or it is VIM or IMP, or all of them are negative? So we may have a option of or the possibility of thinking a porine or efflux pump related problem.
Yeah,
So
and
now
sometimes
if I have a report which says Pseudomonas and is it an NDM or VIM or IMP, so then will it help?
The expert carbar detects only 5 enzymes, and that may not be the only thing that is present. So for Pseudomonas, going with only Chiasv with Astrona would not be a great choice, because there might be other underlying mechanisms which might be present, and these drugs alone may not be effective. So for Pseudomonas, we should be better combining it with the polymyxin B or colistin therapy along with the Chiasv with Astrona.
Okay. So now coming to, there are some questions related to when you have a PDR, colistin resistance. So what will be our options?
In case of a PDR, we can go with the combination of drugs like in PDR means it is even resistant to colistin, but there are very few cases where the colistin resistance is also there. So in those cases, like if it's an E. coli, then we can go with the other drugs like phosphomycin along with the polymyxin B or tigecycline for intra-abdominal infections or
For Pseudomonas, probably we will avoid tigecycline for Pseudomonas. We're talking about Pseudomonas, so polymyxin plus phosphomycin or combining with high doses of aminoglycosides may be the only option. Dr. Monalisa, can you hear us? Okay, I think Dr. Monalisa has not able to connect to us. So the last drug, the last bacteria which has been very common to us is Acinetobacter. So when coming to the Acinetobacter, yeah, ma'am, I can hear you. There is, I think, internet breakage. So when it comes to Acinetobacter, and when your Acinetobacter is Carbopenium resistant, and so what are the most common mechanisms which see in Acinetobacter, Dr. Jaya Banerjee?
So most common resistance pattern is again the phenotypic resistance pattern is more common in those. But here the Carbopenium, because OXA48 here it is not there, OXA 23, 25, the others are there. So here the NDM and all those we do not do it. Mostly the phenotypic resistance patterns are more common in those cases. So the other things we need to check.
So, Dr. Monalisa, when it comes to the Acinetobacter, Dr. Banerjee was saying that the OXA48 is not the predominant one, but the other OXAs became the predominant ones. And now we may see some NDMs, you may see some non-carbapenemase production like porins or efflux channels in them. So what will be your choice when it comes to the Acinetobacter with carbapenem resistance?
For the Carbopenium resistant Acinetobacter, which we call in short form as crabs, for them we can be using a high dose of sulbactam along with the other treatment of choice like the polymyxin B, along with if the site susceptible, then tigecycline may be used for them. And in the case of respiratory infections, we may use minocycline for the Acinetobacter.
Okay, for urinary tract, which kind of polymyxin you will choose, and what will be the options in different?
For urinary tract infections, specifically, we would go with colistin, as it is excreted in the urine and it achieves good levels in the urine. Polymyxin B does not get concentrated in the urine. So for urinary tract infections, specifically, we need to go with colistin if it is an PDR.
So the other question is, which are the areas, which are the times, as we already getting a warning from CLSI that you don't use colistin as a monotherapy, or many of the times we don't use aminoglycosides even as a monotherapy, but what are the areas where you still consider using them as a monotherapy?
If the patient is hemodynamically stable and the infection is not very severe, like it is a skin and soft tissue infection or a non-complicated UTI, then we may go with the monotherapy with the aminoglycosides for the urinary tract infection, or colistin monotherapy, even we may go with it. But in case of hemodynamically unstable severe infections, we would prefer avoiding them. as monotherapy.
There are other questions which I'll take. Can we give fosfomycin for carbapenem resistant Acinetobacter?
No.
The answer is no.
Fosfomycin is intrinsically resistant to
Resistant.
Acinetobacter.
Pseudomonas melli is intrinsically resistant to colistin. That I think he is talking about Stenotrophomonas pseudomelli, Burkholderia pseudomelli. I think.
Previously known as.
So they are all intrinsically resistant. So there are some questions related to the lab turnaround time. What will be the minimum time to get this type of reports, ma'am?
Once the culture comes, then the growth should come. And once the growth comes, it within 24 to 48 hours, with 30 hours, report should come. But the growth has to come first.
So first it is to flag either in the blood or whatever cultures.
The blood is a flag, yes.
So once it flags, then to identify the organism and antimicrobial susceptibility, it takes 48 hours,
24 to maximum 30 hours. Like
so
within
20,
24.
so within a day or so. So
Yes.
in between, you also tell us that there is a gram positive flagging, it's a gram negative bacilli flagging. How do you get that? Do you do any gram stain from that flag?
Yes, sir. Particularly for the blood culture, we receive the blood in the blood culture bottle. So we put it into the automated system where we enhance the incubation. It's a instrument which incubate the things. So once it is flagged, it gives us some signal. We get the bottle out and we do the preliminary gram stain. Then we say that it is gram positive or gram negative to give the preliminary report, so that the gram like coverage, GNB coverage or GPC coverage
so that can come immediately after the flagging.
Yes, immediately.
Okay. What about the fermentation? We do get an information whether it is a lactose fermenter or a non-fermenter.
Lactose fermenter or non-lactose fermenter, it is totally in the smear. It is very difficult to tell. Sometimes we say lactose fermenters, but it turns out to be non-lactose fermenters. It's not very great to tell at that time. But once we will get that bottle, we will inoculate into the culture plate. So once we inoculate into the culture plate, we put into the incubator. The next within 16 to 18 hours, it gives a growth. That time by the color, we can say it is color, and oxidase, by checking the oxidase, we can say it is lactose fermenters or non-lactose fermenters.
So that means the reliability during the gram stain may not be very accurate at that time.
Yes, but sometimes for some organism, it is very typical, so that we can say, like for the Acinetobacter, it is gram-negative coccobacilli. So if it is coccobacilli and the site is ET secretion or tracheostomy secretion, so we can be able to comment on that. Particularly Pseudomonas are the slender bacilli. So it's not confirmatory, but we can say something.
Dr. Monalisa, can we use two carbapenems together? These are all audience questions, so I'm just passing on. We'll see. Two carbapenems together. One carbapenem being a suicidal, the other carbapenem acting on.
There have been some studies which have shown that the dual carbapenems may be used in case of complicated infections, very severe infections.
Particularly carbapenem.
But they are not very great to use, like not much.
Not robust data to support their use in those many of the systems. There are some questions like, ma'am, Dr. Banerjee, there were no particular evidences of colistin resistance. Do you get colistin resistance? There are questions repeatedly. I'm seeing Vitek doesn't actually detect colistin resistance. Is it true? We get colistin resistance.
No, it is colistin resistance. It can detect, but according to CSI guidelines, the microbroth dilution method is the best method for the confirmation. So whenever, very rarely we get in the Vitek that colistin resistance. So whenever we get, so we used to do the microbroth dilution also parallelly. So whenever for the colistin, particularly we get the Vitek report along as well as the microbroth dilution regularly.
So you confirm it with microbroth dilution, even though you get a resistance.
Yes, microbroth dilution is the ideal method. So we do regularly.
But we do not report them sensitive. It's all about a problem with sensitive. It is only either intermediate or resistance.
Or resistance.
You get resistance in a backtech, you go back and do a broth dilution and confirm it.
Even in case of sensitive intermediate also, for some cases, critical area cases, we do the microbial dilution simultaneously along with the Vitek.
So the importance of lactose fermenter and non-fermenter, I think many of our clinicians do ask our microbiologists to guide us. As Dr. Monalisa pointed out, when we get a GNB growth and we know it is a GNB, then we wanted to, if the patient is already on one of the broad spectrum carbapenems, and also we are not getting adequate response, so we wanted to cover the XDR pathogens. So we wanted to know whether they are CRE, that is the carbapenem resistant Enterobacteriaceae family, or they are Pseudomonas or Acinetobacter and all. The reason for that is we wanted to direct our therapy accordingly. If I have a patient who is already on a carbapenem and still the patient is growing a gram-negative organism and that lactose is fermented, so probably I'm dealing with an Enterobacteriaceae family.
Yes, sir.
My direction of the therapy is probably more towards giving a ceftazidime avibactam in combination with azithromycin will be my priority. Whereas if I get a non-fermenter, which the possibilities of Acinetobacter and Pseudomonas comes, then probably I will think about giving a drugs combination which is polymyxin driven. Like the polymyxin is my backbone, adding to that other. So that is the importance of both lactose fermenter or non-fermenter, which information I get during the initial phase of my culture reports. Ma'am, there are questions related to the clindamycin sensitivity in a culture report.
Yes, for the GPC, gram-positive cocci, clindamycin is important to find out the clindamycin inducible resistance is there or not. That is important for gram-positive, but gram-negative reports, clindamycin doesn't have any value, and moreover, the intrinsic resistance is also there for the enterobacterials for the clindamycins.
Ma'am, there are some questions also that I have seen when good labs with NABL certified and a very standard microbiologist reporting, they do not report the pathogens which are none probably they are not a part of pathogenic organisms. Something like when you don't report as candida when it comes in a sputum. Yes. Or when it comes in a ball specimen. In the same ways, there are some questions related. Why do we actually give sensitivity and resistant report of the drugs which are intrinsically resistant? This will create a lot of confusion in the clinician. That's true, but it is particularly linked to the lab. The lab yes. needs to be standardized. The lab needs to be optimized. The microbiologist and the lab team should get optimized that we do not report those things which are probably will confuse the clinicians and add problems to the clinicians. Ma'am, there are situations other than candida. What are the other things which you do during the reporting?
So for particular organisms, our commensals being like pathogen for some sites, whereas they are commensals for some other sites. Like candida is commensal for the respiratory system, any samples. We do not report usually the candida unless and until the patient is very sick or any suspicion is there for the thing, then we report. In case of blood bacteremia, of course, if candidemia is any candida is there, we report it. In case of urine also, sometimes candida we observe, but that time that may be the colonization, because maximum time we see the patients are in catheter. So colonization can be there. So in those cases, we need to correlate with the condition, particularly in the respiratory and the urine. Those cases, we do not report the candida. Then, but in case of blood, definitely we'll report. So depending upon the organism and the site, we need to decide that what is pathogen and what is commensal and report accordingly.
There were two common actually concepts. Most of the times we discuss with our microbiologist and in clinical round. Patient responding well to the existing antimicrobial and lab reports resistant. So this is one situation. The other situation is lab says it is sensitive, but patient is not responding. So Dr. Monalisa, how do you actually defend yourself to this?
There is a difference between the in vitro and in vivo sensitivity of the drugs. And there is the 90-60 rule, which says that even in case of sensitive, the AHT report showing is sensitive, it may not respond in 60% of the times, and it may respond only in 90% of the time. So the 90-60 rule applies.
So So that means sometimes the in vivo you may have a variability from in vitro. So you will still have a error of 10%, and sometimes you may have a lucky that you are in vivo, the patient may get response to your antimicrobial. So
yeah, but
need to
we
look-
should be guiding our therapy by the AHT report only, not by the 90-60 as such.
So does clinical response do play a role? Suppose a patient is responding well, will still you take AST report and change your antimicrobial in those situations?
If the patient is responding well, and then we like may consider to continue with that, but we should be having a close monitoring and accordingly measure other parameters as well, clinical parameters and lab parameters to measure the response.
Okay. So I think we are crossing our time. So we have been almost an hour and a half, and there are almost another 60-50 questions on different chat boxes, which we probably take on in the next session. And I enjoyed thoroughly the session. I thank Dr. Jaya Banerjee, our clinical microbiologist and infection control in charge and infection control officer, who actually enthusiastically take a very lead role in infection control and probably antimicrobial stewardship. I thank her for bringing this information to all of us and enlightening us, and spending her time for the last week in preparing the slides and bringing to all of us. And I also thank Dr. Monalisa Sahu, who has been our infectious disease specialist for our group of hospitals in Yashoda on all the 3 hospitals. And he's being the only infectious disease specialist who has been guiding the whole clinicians in the different areas of ID. So I thank Dr. Monalisa for her guidance and the presence here and giving all this information. I thank all the other audience who have been a part of this symposium and were asking many questions. I think I could cover many of them. There were a few repetitions. We will bring this topic with probably a few more additions to the gram-positive side. We could not cover it today, and in future we will bring that. And with this, I thank everyone who has been a part of this and conclude the session. Thank you all, ma'am.
Thank you, sir. Thank you so much for appreciation. Thank you,
Thank
sir.
you.